I think to begin with, when we actually initiated these studies, we went into preclinical studies, looked at the cell line efficacy, we looked at the toxicity profile, and then we went into dosaging planning. Our understanding of this is still further evolving. Today, under the Ayush Ministry, this particular product has been given an official authorization to be used in humans based on some of the very strong data that was shown and based on the efficacy of the potential herb along with other constituents, and in addition to this, the previous data that has already been existing in science. Now, who are the most eligible patients? Today we know epithelial cancers and leukemia patients. The guidelines suggested to us that it is best to first start using it in patients who have exhausted first-line therapy. First criteria. That means they have tried first-line therapies and they've completely failed in it and have no other hope. Or in patients who, in addition to this, have not been able to afford or able to reach out to the first-line therapies and under compassionate grounds are requesting for it. In addition to this, there is a category of patients who are very high risk for reoccurrences. And in such kind of patients, where we know that in the first 2 years to 5 years, the chances of a tumor coming back are very high, this would play a potential role. So today we are in the process of many ongoing studies that are trying to answer these fundamental questions to open up more specific indications subsite-wise. So we know today that in head and neck cancers, colon cancers, breast cancers, or in certain other salivary gland cancers, or in pancreatic cancers, leukemias, lymphomas, there has been very, very good results that has been shown in cell line studies and in preclinical data. How does this translate into actual efficacy in patient-wise data is something that we are going to closely observe. Another very important component that we understood was the importance and the power of metronomic dosing. Because even at very high doses, we did not find toxicities, and these were all done in US FDA-approved labs. Even in very high doses, these particular products did not show toxicities, showing us that there was something in the immune system that gave it some amount of anchorage, some amount of shelter to protect it while giving it the necessary therapeutic advantage. So with that, we are today also looking at metronomic chemotherapy dosing, which means that this can be taken along with conventional chemotherapies. And we've had studies comparing this particular formulation along with conventional therapies like cisplatinum, paclitaxel, 5-fluorouracil to compare its efficacy. And what we found is metronomic dosing, which is a very well entrenched approach in allopathic science, talks about a simple formula that when you cannot blow a building, when you cannot blow it away and break it, try to remove one brick at a time. This is where you are able to kill the cancer cells one by one while activating the immune system. And Simarouba seems to be having the potential in metronomic dosing also to achieve certain therapeutic targets of great palliative goals over a period of time when it is used, not instantaneously, because it doesn't give that instant cytotoxic effect. So the coming days will be very crucial for us to uncover more amount of these answers, patient-wise data, population-wise data world over, and we are all quite optimistic in this front.